Okay.
Perfect. So today's webinar will be all about dispelling hospice myths so that we can get to the facts. Let me take a moment to introduce our speaker, Leesa Hillman. Leesa is a registered nurse who currently works in hospice care. She has 14 years of experience in hospice, where she started as a CNA, then LPN, and eventually RN. She graduated from Weber State with a Bachelor's of Science in Nursing. Currently, she works as a hospice liaison, where she spends time explaining the benefits of hospice to patients and their caregivers. Leesa feels so grateful to have found a specialty in medicine that fills her bucket each day. Leesa loves to share and educate others about the gift of hospice care and how it touches patients' life. Hospice is such a tender chapter in her life, and Leesa is privileged to be a part of it. I love that intro, and now I want to turn our time over to Leesa. I'll stop sharing my screen here.
Thank you so much for the introduction. Like Cindy said, I started hospice almost 14 years ago as a CNA, and I just fell in love with the patients, just the idea of hospice, those tender moments that I had one-on-one with the patient that was going through one of the hardest times of their life. And so I just felt really privileged to be able to be a part of that and to give support and guidance and education. If you learn anything out of this webinar, hospice is all about education, and it's such a supportive program. I just want you to know that right off. HealthTree staff did ask me to pick a topic, and I thought it'd be really important to have just a general idea of what hospice is and to really debunk those hospice myths and really get down to the facts of what hospice can do for a patient that is at that end of life process. Over the years, I've found that meeting with families and patients, there are a lot of misconceptions about hospice, and that's what kind of contributes to that scary word of hospice. And so I kind of want to clear that up. I love being able to meet with families every day to really represent what hospice really is. And so I would like to say, what is hospice? Hospice is when it's a specialty care program that starts to focus from curative to more of a comfort level of care. And so hospice is paid for by Medicare Part A, and the care team includes a registered nurse. Sometimes you can have a visit LPN that comes and sees you as well, or LVN, depending on where you're at. A CNA, a social worker, a chaplain, and then we'll always have a medical director that is over the hospice care. And of course, we might have volunteers. Hospice was actually founded on volunteerism. And so that's another benefit of hospice. So kind of talking about what is hospice kind of brings us to our first myth. And that is hospice care is only for people who have given up on life. And I just kind of want to read a statement about that. It's a common misconception that hospice is about dying, when in reality, it's designed to help terminally ill patients live their final days to the fullest. The National Hospice and Palliative Care Organization considers hospice care the model for quality and compassionate care for people facing a life-limiting illness. It provides medical care and pain management, as well as emotional and spiritual support tailored to the patient's needs and desires. The ultimate goal of hospice care is to increase the patient's quality of life and provide support for family members and caretakers to ensure that the patient's final days are as comfortable as possible. So no, it's not for those that have given up on life. It's actually just enhancing those with a terminally ill disease. So that was our first hospice myth. And I have about 14 myths that we're going to go through. So if you want, you can write down ones that you might want to ask questions about later. So number 2, once you enter hospice care, you can never go back. This is something that when I meet with families for that first Hospice 101 meeting, I like to call them Hospice 101s because it's a lot of questions and answering when I first have that initial visit with them. And no, that is not true. You're not, I always say, you're not signing in cement. You're not signing in stone. A lot of patients actually come on and off of hospice because you do have the right to go to the hospital. Now, if you're admitted to the hospital, we would actually have to discharge you off of hospice services. So that way Medicare pays for that hospital stay. And we don't want patients or families to be left with medical bills. And so no, you once you're on hospice, there's even times when patients do a little bit better and perk up and no longer qualify, and so they actually come off of hospice for a little bit until they have um, a little further decline in their disease process. So that was another one. Um, Number 3, hospice care is only for people with a few days or weeks to live. And I kind of want to add to that. I think that a lot of people think that you have to be bedbound and actively passing. And I think maybe in the past that's what it used to be, but nowadays hospice is a very vibrant program, and we actually find that starting patients on hospice care earlier is so much better because we're not only able to get to know the patient, their needs and wants of their end of life care, but um, we actually get to know them. We get to know how they like things done. We're able to manage their pain and their symptoms, and we're able to catch things before they get worse. And so sometimes, on hospice, you can treat infections. And so we're able, because we're coming in the home weekly, or multiple times a week, we're able to catch things before they progress worse. And so we can, treat UTIs, we can treat upper respiratory infections before they become really debilitating to the patient. So we actually, as long as we're able to get a hospice order that the physician says that the patient has a life expectancy of 6 months or less, and that's kind of just the guideline, because we've had patients on hospice much longer than that. And as long as we're able to show that they're having consistent small decline, then we're able to keep them on that hospice service. Myth number 4, entering hospice care means giving up control over your care. And for this one, that's an absolute no. I feel like when you enter into hospice, you're really finally able to have complete control over how you want your end of life care to look. And so hospice is all about honoring the patient's wishes and how they want to be treated at end of life. And so I'll just read something here. Hospice care is intended to increase quality of life for terminally ill patients, so it cannot be forced on anyone. This form of care is administered by a team of professionals specially trained to provide care and support to meet the patient's medical, physical, emotional, and spiritual needs. So treatment varies on a case-by-case basis. The patient always has the right to request or refuse services. So even though we have the nurses, CNAs, social work chaplain, you can actually refuse some of those services. So some people don't want a chaplain in the home. Some patients prefer not to have CNAs because they're pretty independent still. And that's the beauty of hospice is we tailor it really individualized to each patient. So you have lots of control when you're part of the hospice program. Myth number 5, your family has no control over your care once you enter hospice. So families, a lot of times, or the caregivers are the main support for that patient. And I think sometimes families are a little bit frightened that once hospice steps in, then they no longer have control of the situation or suggestions. And that's not true at all. Hospice care is for the patient's family just as much as it is for the patient. And throughout hospice care, and even following the patient's passing, both the patient and their loved ones have access to support services, including grief counseling, social services, spiritual guidance, and other resources. And so we actually will follow a family for 13 months after the patient has passed. And so it's even additional support for the family after the passing. Myth number 6, you need a doctor's referral to enter hospice care. That one's a little technical. It is true that we need a hospice order, but we don't have to have a doctor suggest hospice. Families and caregivers can actually go to their physician and say, hey, I think we want to look into hospice. And so from there, we can have the physician maybe suggest different hospices, or the families can research local hospices that they want to interview. And one of my parts of educating people is that it's really important to interview multiple hospices, because this is your care at such an important and pivotal time in your life that I think getting the right fit is important. So not all hospices are created equally. They all are, supposed to give the same benefit, but everyone kind of services their patient differently. And so I think having that connection with your nurse and the care team is really important. So it's okay to interview multiple hospices. You have that right. And I suggest doing that when the time is appropriate for hospice. Myth number 7, hospice care can only be given at a hospital or a hospice facility. There's a lot of times when I meet with families and they think hospice is a place. Hospice is somewhere we have to go, and our loved ones have to leave their home to go to hospice. That's not the case. Hospice goes to wherever your home is. And so whether that's at home, or at a skilled nursing facility, an assisted living, at the hospital, at a hotel. I've had homeless patients before that I've actually gone to visit at a hotel. And so hospice care is given where the patient calls home. And so I think that's a really important thing to know. Myth number 8, hospice care and palliative care are the same thing. This one can be a little tricky as well. One of the most important hospice facts any patient should understand is that it is a different service from palliative care. So palliative care, you might still be having some curative treatment, but you're also focusing on comfort and symptom management. Hospice, we're no longer seeking curative, but we are still seeking comfort and symptom management. So that's kind of the difference, is that palliative, you can overlap with some curative care. So you might still be having some interventions, might still be having chemotherapies or radiation, but the hospice patient is different, that they kind of stop those bigger treatments and looking more towards just comfort. Myth number 9, only patients with cancer can benefit from hospice care. And that one's a big myth, because about 70% of hospice patients were non-cancer patients. And so there's a little bit of data, like we have heart disease is probably the highest hospice patient. And then dementia, lung disease, stroke, kidney disease. And so hospice is for everyone with a terminal illness. It's not just for cancer patients. Myth number 10, hospice care is very expensive. Hospice is covered by Medicare Part A and some Medicaids. And if you don't have Medicare, some hospices will actually do a pro bono case. I know that the companies that I have worked for have done pro bono, which means that they will take like a charity case, like they'll pay for your hospice for free. Veterans have a benefit of hospice care that the VA pays for. And then certain insurances, and I won't go into that because everyone is so different and there might be a copay. But for the most part, Medicare is covered 100% by Medicare Part A, and that includes medical equipment, hospice covered medications, all of the care that comes into your home. Myth number 11, hospice care doesn't make much of a difference. And I can absolutely say hospice makes all of the difference when you're having a terminal illness and you're entering into those end of life stages. And I just wanted to say that there's so many research studies that say when a patient is on hospice, they actually live longer than those that have a terminal illness that do not have hospice services. And why do you think that is? I'll just kind of ask that as a rhetorical question. I will tell you that you have caregivers coming into your home weekly that are staying on top of symptoms, staying on top of your comfort, your quality of life improves with hospice care. And so you're feeling better and um, we're able to manage infections quicker. And so having that extra TLC coming into your home or to, wherever you call home, really helps that quality of life and actually extends life in some cases, and lots of different research studies out there. Hospice care, and myth number 12, hospice care ends with the patient's passing. And I kind of already talked about this. That's not true because hospice actually um, checks in with the family for 13 months after the patient has passed away. And some might ask why the 13 months versus just a year. And that's because we actually help you get through that 1 year anniversary of the patient passing. And so we're still checking on you. And in some cases, there's hospices that will continue because you build such a close relationship with the care team. We'll continue to check on them even after the 13 months, but part of that benefit is the 13 months. And then myth number 13, I have to give up my primary care physician when I sign up for hospice. And this is really important for some people because they're so attached and just love their primary care physician, has been seeing them for over 40 years or more. And they are sad to leave their primary care physician, but you actually have the right to keep your primary care physician. There will always be a hospice medical director over your case, but you can still have your primary care as your hospice physician. I will say though, with experience, I think it's always nice to have them as a consulting physician, only because that hospice care team has direct access to their medical director. And so we get orders really fast. We're able to move things a lot quicker. Whereas if we're asking for orders from your primary care physician, it's kind of when they can get to it. And I don't know, some are a little bit slower to get us orders and information back. And so I always like to say, you can use our hospice medical director, and then we can consult and update your physician because a lot of times those physicians want to continue seeing you as well, or at least know what's going on with your care. And then this is probably the question I get the most. I have to stop all my medications once I start hospice care. And I think that a lot of people think as soon as they sign up for hospice, they have to stop all their medications and pass away. And that's not true at all. We actually like to continue as many of the medications as possible at the start of care. And when appropriate, start discontinuing medications that were no longer appropriate or no longer helping that disease process. And so there's always a time and place for stopping medications. But never when you just start hospice care. And I will say some medications are covered by hospice and some are not. And some of those more curative medications we'll talk about at the initial admission to hospice of what medications will be covered and which ones will not be covered. And then that will be the patient's responsibility, or the other insurance can pick it up. But definitely, just because you come onto hospice care doesn't mean you have to stop your medication regime. Like, we want to keep it as constant as we like to make few changes as possible because we want it to be the smooth transition. And then of course we'll add medications for comfort if that's appropriate at that time. Um, really, those are probably the most myth questions I get at an initial meeting. And so I just want to leave you guys with hospice is such a beautiful program for the appropriate time of when a terminal patient is needing that hospice care. Um, I've seen patients that have chosen not to have hospice, and it doesn't go as smooth. Hospice is so supportive. It's an education program for the family, the caregivers, for the patient themselves. You know, when it can be a scary time of what's next. And a lot of times we can have an educated guess of, listen, this is kind of where you're at, and this is what we can expect in the next little bit. So it's been really helpful. Again, I would say if you're ready for hospice, interview multiple hospices to find that right fit for that care team. And that's kind of what I have for you guys today. And I'd love to answer questions because I know there's probably questions.
Perfect. Thank you so much, Leesa.
Yeah.
I'm going to just share my screen again and remind everybody how to access the chat. Again, with this being a group that we can ask questions by raising hands, feel free to do either one. So you can ask questions or make a comment by typing in the chat box or by raising your hand. If you're raising your hand, just wait to be called upon and then we'll ask you to unmute yourself. But I have some of my own takeaways that I loved learning about today. So number one, I thought it was amazing that the hospice continues for the caregivers for 13 months. That is such a wonderful gift, I think, to know that that love and care is going to continue on after as well. So I love that. But I guess my question was when you talked about patients going on and off hospice care, if they need to be admitted into the hospital, they'll come off of hospice care. And then once they're discharged, how long does it typically take to get that hospice care back up and running?
Established care.
Yeah.
We're actually usually part of that transition home. So I know for our hospice, we will actually transport them if needed from the hospital back home and admitted that same day because we don't want them to have a lapse in care. So yeah, that's what we typically did was immediately as soon and we coordinated with the hospital so that way we knew their discharge time and then that they would be coming back onto hospice. The other thing is can you go to an urgent care? You absolutely can go to urgent care. We've had where people might have needed stitches from a fall. And so family members would take them to the urgent care, stitch them up. And because they weren't admitted, we can still continue care without having to discharge.
Perfect. Thank you. We've got a question from Claire. She asked, can you enter hospice without a family or caregiver? How does hospice accommodate this situation so if they don't have additional help in the home?
Absolutely. We have lots of patients that may not have family or caregivers, and they're just that, just the patient. And absolutely, that's probably where hospice shines the most because we are your resource. And as things progress and you might become less or more and more dependent on care, we make sure that you're safe at home. And if it gets to the point where it becomes an unsafe situation because you need more care in the home, we first try to start with private duty care, which is paid for out of pocket. And sometimes if you're with the VA, there's some benefits there that they'll pay for a little bit of care, but we help you get into assisted living or skilled nursing. It kind of depends on the situation, but we try to keep you in your home if that's your ultimate goal to stay at home or pass at home as much as possible. We can utilize our volunteers. We can, like I said, there's other resources out there that can help pay for some personal care That way you're not home alone, and you're always being checked on.
Perfect. I love that. Um, I love the collaboration and that love as well. I think that's amazing.
Yeah.
Um, Fred responded in here that caregivers may live longer too. So that, of course, is going back to the fact that the hospice is still available for the caregivers for 13 months, which is
Yeah.
awesome.
And Cindy, just to kind of add to that too, I think that sometimes patients are a little bit fearful to to pass away because they're worried about their loved ones being left behind and if they're going to be checked on, especially when it's spouses and they're both maybe at an elderly age. um, it gives them kind of that peace of mind that people are still going to be checking on them. And they develop such a close relationship and become friends, and so I think they feel a little bit more comfortable too, that they know for 13 months my loved one's going to be checked on.
That's perfect. Trying to think, we don't have any other questions coming in yet, but one other thought or question that I had was if you could maybe talk more about hospice being covered by Medicare Part A, any sort of specifics that they would need to know in order to get that coverage?
Yeah, so I think it's important to know that there are qualifications with each diagnosis. And so there's criteria that Medicare puts out there. And in that disease process, the patient has to meet so much criteria for them to be able to get that hospice Medicare benefit. And each diagnosis, the reason why I didn't go too deep into that is because each diagnosis has their own set of criteria. And it can be pretty specific, especially with cancers. Maybe not as much with blood cancers, but certain cancers, it depends on like the origination of where that cancer was. Because a lot of times we have the metastasized cancers. And so we have to find out what the origination point was for that cancer and then go off of those guidelines. And so how hospice works is you have your hospice evaluation. We come up with a admitting diagnosis. And for 90 days, it works in certification periods. And so for the first 90 days, you're on hospice services. And then we need a face-to-face from our medical director or a nurse practitioner that comes in and certifies, yes, this patient still needs care, hospice care. So then for another 90 days, we provide care, and that's at that 6-month point. From that point, you have another face-to-face from the doctor, and they visit you in your home. You don't have to go anywhere. All of your care is brought to you. After, if they certify, yes, this patient still needs hospice care, then it's every 60 days after that. And what we have to do as nurses is we have to chart to your decline. So a lot of times the nurses in the hospitals, they're charting all the good stuff, how you're getting better, how you're improving. But we actually chart opposite, and we chart to your decline and show that they still need these services because of this. They're having this weakness. They're continuing to deteriorate this way, so that we can qualify you and keep recertifying you every 60 days for hospice care. And there is no cap to that. Everyone declines at a different rate, a different pace. And so everybody's body's different. And so there is no like cap to it. We just, if you do kind of stabilize for a long time and we feel like you haven't had decline for a long time, then we might have to take you off of services for a little bit until you have more decline. And hospice always preps you, before a discharge. If we feel like, okay, you're doing pretty good, we might want to try home health for a little bit where it actually strengthens you. Sometimes that happens, not a lot with cancer patients because we know that that's so progressive, such a progressive disease, but sometimes with other disease processes, we take them off for a little bit and wait for that decline.
Okay, thank you.
Yeah.
One other question I had was, you mentioned, of course, interviewing different hospice providers. Being a nurse as well, I know we see some of the best and the worst, and I'm wondering what type of questions would you use in that interview process to make sure that you're getting the very best care possible?
That's a great, great question. You want to talk about visit frequency. How often am I going to have the nurse come to my home? How often am I going to have CNAs come to my home? Do you have, I should probably go a little bit slower, but, oh, and this is recorded, so they can rewind it, right?
Yes.
Do you have an on-call team? Because it's really important. It seems like all the bad things happen in the middle of the night or on the weekend for whatever reason. Um, and so do you have an on-call team that's at your phone call, every 24/7? So you want to be able to have someone on call. Am I going to have consistency with my nursing visits and my CNA visits? I think that's really important. I will just say my standards are that a patient has a CNA in the home at least 3 to 5 times a week. There are hospices out there that only send one out maybe once a week. And Medicare, the criteria is that we have to have a nurse visit every 14 days. That's the um, regulations. But like for our hospice, the nurse visits twice a week minimum. And so that's really important to know your visit frequencies. How often is my care team going to come to me? Because that's what it's all about is being on top of symptom management, being on top of my comfort.
Absolutely. Um, I like that breakdown of exactly what that expectation will be ahead of time. And then if that expectation isn't being met, is that a situation where you would suggest maybe going to another care
Yes,
provider?
that leads into another really important thing is you have the right to transfer to another company if you feel like where you are receiving your hospice care is just not providing the care or you're just not quite vibing with that team. You can transfer to another hospice company. And I really don't think there's a cap on transfers either until you find that right fit. But there are so many great hospices out there, but there are some that don't give as much care. And I think at this time in your life, it's really important to get as much care as possible.
I agree. I agree. We've got a couple of comments, of course, thanking you for this and telling us how incredibly comforting this is. So that's wonderful. We have also another question about what is a CNA? So could you just talk through
Oh,
what a CNA typically does, an RN, where the different levels play?
perfect. Yeah, I forget that sometimes those acronyms are people don't know. So, an RN is a registered nurse, and she's going to be the one that's really, we call them a case manager. So she's going to be, she or he is going to be over your care. And what she finds in her assessment, or he finds in his assessment, he brings back to the doctor where our care team meets with the physician every 14 days to talk about your case. We talk about every patient's case and how it's going, what changes might need to be made, just the progression of the disease process. And so that's what the nurse is doing, going in and making sure you have your medications. They're checking your vital signs every time you go in because you may feel the same, but if we start seeing some vital sign changes, then maybe you're dizzy because you're still on your blood pressure medication, but you don't really need the blood pressure medication anymore. Those are the things that she's monitoring. And then the CNA stands for certified nursing assistant, and so they are like your personal caregiver. They come in and um, as you start needing more and more help, maybe in the shower, they'll come in and help you with your showers or at least be a standby. Um, as you become more bedbound, they might help you with a bed bath. They really are there to help support you with your personal cares, brief changes, oral care, hairdos, nails, things like that, to really help you with those personal cares. And then our social worker is there for psychosocial needs. Chaplain is there for spiritual needs, and the chaplain is usually non-denominational, so that it's open just to any religion or any belief. And um, they usually have a lot to offer just spiritually and just as a support. It doesn't mean that you have to be part of an organized religion, but It's just kind of another person to come in and lay eyes on you and to talk to and support you through this process. And then our
I love
medical
it.
director, he's just over everything, signing orders, giving suggestions on medication changes or different kind of interventions to help keep you comfy.
Perfect. I love that it's such a compassionate, collaborative specialty, just making sure that your whole care team is giving you that comfort, not only to yourself, but also to your family members. It's just a very great collaborative specialty. So it looks like that is it for questions. I'm going to just give maybe 1 or 2 more seconds to see if there's any others or if anybody wants to raise their hand. I know I've learned a lot today. I had an idea of what hospice was, but definitely did not understand the scope completely. So thank you.
It really is such a beautiful program. I Families after their loved one has passed, they're like, I don't know what we would have done without hospice. And some will say, I wish we knew about this sooner. And so that's my goal in life, is to educate people to come on to hospice services sooner because there's such a big benefit. Um, and when people or doctors, refer in those last couple weeks of life, it's just a little bit more hectic trying to get them comfy, getting their equipment. Not that we can't do it that close to passing, but it's just so much nicer getting to know that person as an individual, knowing how they like their showers, how they like this or that, and being able to honor them and get to know them. And gosh, it really is such a special time. And I love the hospice benefit.
Thank you. We've got one more question from Fred. He's asking if we can talk a little bit about the volunteer roles. Maybe you could get into how a person may offer to be a volunteer, but then also talk about what the volunteers would do on the inside.
So typically with volunteers, when they come to us to want to be a volunteer, they go through a pretty rigorous, background check and education. Um, they're not really able to help with cares, and so typically it's sitting with someone, playing cards with someone. Sometimes families need a break. Oh, I didn't talk about respite. I should talk about that. Um,
Thank you.
Sometimes families need a break just for an hour to go to the grocery store, to go, take a walk outside. And that's kind of where we utilize our volunteers, is to just come and sit with a patient, try to find something that they love and sit and do that with them. Some volunteers come and read to our patients. Um, there are different levels of care in hospice. I just want to cover that really fast. Um, so There is routine care, so that's just when you're admitted to hospice, you're taken care of by our team. And then there's general inpatient. That's where we feel like we are just not able to manage your symptoms at home. We need to get you to a skilled nursing facility or a hospital where we can have an RN there 24/7 taking care of your needs. And that some patients qualify for that, but it has to be that we really don't have we're not able to manage your symptoms. So that's that highest level of care. And then we have something called continuous care. And continuous care is where the nurses at the bedside pretty much know, no, you're never left alone without part of our team there. And so that's continuous care. I don't see that as much. I think it's kind of underutilized, but I think it's a little bit harder for hospices to staff, but that is part of the benefit. And so if they have that continuous care need, then hospices try to stack the visits. And then there is respite care. And respite care is so important to know that you have 5 days each certification period to give the caregivers or the family members a break. And so we're able to take the patient from their home and place them in a skilled nursing facility for 5 days, so that they have 24/7 RN care. And that just gives families a break. We've had where patients, families, the main caregiver got sick. And so there was no one else to take care of them. So we were able to give them a respite stay at a skilled nursing facility, and the hospice pays for that stay for those 5 days. And so that part of the benefit of hospice. And so you get those 5 day stays every certification period. So remember, the first certification is 90 days, then 90 days, and then every 60 days after that. So that's a really
Thank you.
great point I should have brought up.
No, that's great. Thank you. And I like, with it going back to the volunteer roles, knowing that those volunteers will be screened. They're going to be people who are skilled, not of course doing the cares themselves, but being there as another support system for the patients as well and for their families.
Yeah.
Yeah,
During COVID, we saw a real decline in that, and it was really sad because of regulations. We couldn't have our volunteers go into certain facilities. Families were more hesitant to have volunteers come into their home, and it was just that unknown of having a person come in from the outside, come to your home. And so it was kind of sad when we saw the decline in volunteers and even people signing up to be a volunteer. But we're seeing a rise again, and it is such a good benefit.
absolutely. And I can't remember if you touched on this, but if somebody wanted to volunteer, would they just go to the individual hospice
Yeah.
companies, or how does that work?
Yeah, I think there's actually volunteer websites where you can put your name in, and then they find organizations for you that are looking for volunteers, because I know that's where we find some of ours. But yeah, I would just call your local hospices if you wanted to be a volunteer, and they're always looking for help.
I love it.
Yeah.
Okay, perfect. I think we've got all the questions. So we'll go ahead and wrap up. And again, thank you so much, Leesa.
Yes.
I learned so much, and I know a good comfort to the people who joined today as well. It's such a
Good.
vulnerable topic. And I want to applaud everybody who joined today again for that vulnerability and for sharing this time with us and learning from Leesa. So thank you.
Yes.
Um, so that is all we have for today. But before we go, we'd like to mention one of our very important programs called HealthTree Cure Hub. At HealthTree, we believe that educated parents and researchers create better and faster cures. HealthTree Cure Hub empowers patients with the knowledge they need to actively participate in their health journey, while providing researchers with valuable insights from real-world experiences like yours. We invite you to join the 12,000 and counting blood cancer patients who are currently impacting their outcomes while accelerating research by participating in Cure Hub. Cure Hub is a one-stop platform that provides the ability to connect you to surveys and studies, securely connect your medical records to track your disease within one singular user-friendly interface, discover clinical trials, personalized you, anonymously connect you with your genetic twin matches. Lastly, gain access to a database of side effect solutions provided by other blood cancer patients. You can enroll in the platform by visiting the link at the bottom of this slide. Here are our upcoming events. Later on today at 3 p.m., we've got our virtual HealthTree Cure Tour. June 27th, our Black myeloma community will hear from Jay from our HealthTree research team, who will discuss exploring HealthTree research opportunities for the Black myeloma community. And then Monday, July 1st, we're going to hear from our palliative care for blood cancer patients and caregivers. So going kind of linking along with our talk today. The link to sign up for any of those events and even more events I haven't mentioned today is found at the bottom of the slide and will be sent out in the following follow-up email within 48 hours of the event completion. I would like again to thank our sponsors for their support: AbbVie, Adaptive, Astellas, Bristol Myers Squibb, Genentech, Johnson & Johnson, Pfizer, Regeneron, Sanofi, and Servier. Thank you for helping us build a strong HealthTree community. Please don't hesitate to reach out to me if you have any questions. My email is on the screen, and I hope you all have a great day. And thanks again, Leesa.